Good morning, everyone. My name is Ludovic Reveis. I am the Unit Chief of the Science and Knowledge for Impact Unit at the Evidence and Intelligence for Action in Health Department. We are going to start the webinar on genomics in public health. This session is going to focus on health technology assessment. This session is organized with the Health Technology Unit at the Pan American Health Organization. So this session is, we have interpretation into Spanish and English. So if you can go and then in interpretation, switch and listen to the language that you want. I'm going to introduce now my colleague, Alexandre Legruber, who is the unit chief, interim unit chief in the Access to Medicine and Health Technologies unit, Innovation and Access to Medicine and Health Technologies EMT department. Alexandre, please.
Thank you. Thank you very much, Ludovic. And this is a pleasure to be here. And I will be brief. This webinar is one more activity that our two departments organized together. Department of Ludovic, which is Department of Evidence Intelligence for Action in Health, and our department is Innovation, Access to Medicines and Health Technologies. Has been a pleasure working with Ludovic and the team in the last several years on various subjects, including our work with member states to support the strengthening of integrated systems on evidence-based decision-making, including health technology assessments and clinical practice guidelines. Have been working together and try to build these systems with coherence in alignments in an integrated fashion between our works, in our case on health technology assessment, and Ludovic and building and developing practice guidelines. We have also been developing integrated activities between regional networks. We are responsible in our department for the secretariat of the regional HTA network we call REDETSA. And in the last few years, we had the opportunity to develop joint meetings between the networks. For example, one meeting that a few years ago, we had a joint meeting between REDETSA and the network that works with clinical practice guidelines. And very recently, we had a joint meeting between REDETSA and the VIPNet, together with Ludovic in Jamaica. First time we had this kind of meeting in the Caribbean. And also there was a great opportunity to integrate our work and to bring this message of the integrated work to member states, which was really well received by member states. And more recently, we had started working with this subject of genomics. There was a workshop in Brazil last year that was organized by the Department of EIH, but we organized together a session on health technology assessment, and my colleague Vania Canuto was there, and was a very, very successful session. And right now we are here to one more activity together. So I really think that this collaboration, interprogrammatic collaboration, is very productive with our department. So Ludovic, thank you very much for this invitation. And I would like to, I know that there are several members of REDETSA connected. Would like to say hello to everybody from REDETSA, and of course all the participants connected. I can see that we have more than 200 participants at this moment. We can see that there's lots of interest in this subject today on the use of HTA for genomics and decision making and evidence-based decisions. So thank you so much, and the floor is yours, Ludovic. Back to you.
Thank you, Alexandre. And so I'm going to introduce the moderators. Gabriela Repeto is a member of the WHO Technical Advisory Group on Genomics. And Vania Canuto is a technical officer, development of research and production ecosystem for health technologies at the Pan American Health Organization. Vania, Gabriela, please go ahead. Thank you.
Thank you, Ludovic, and thank you to the speakers, the organizers, and the audience. Indeed, health technology assessment is a key component of implementation of genomics in health, so this is a very necessary conversation. We are pleased to have three experts in this area with us today. They will each speak for 15 minutes. And I would like to ask you to please put your questions in the Q&A box so that they don't get mixed up with all the salutations in the chat. And we will take those questions at the end of the session. So our first speaker today is Professor Ilias Goranitis. Very generously at very late hours at night. He is the head of economics of genomics and precision medicine unit at the University of Melbourne in Australia, and is the economic lead of Australian Genomics. And he will speak about genomic technologies, the value and cost effectiveness. Thank you, Dr. Goranitis. I think your microphone is off. If you could turn that on, please.
Thanks, Gabriela. I'm grateful to the organizers at the Pan American Health Organization for the honor to be part of this webinar. I hope you can see my slides now. Thank you for the honor to participate and talk about the value and cost effectiveness of genomic technologies. Navigating the challenges and the opportunities of evaluating and implementing genomics has been in the core of my research and with Australian Genomics over the past approximately 7 years now. So I'm going to reflect on the work that we've done with Australian Genomics to evaluate and implement genomics, but I will also reflect on the broader evidence review that we've done with Cancer Australia and the World Health Organization. Inherent to our discussions today is the complexity of genomics. And we have a breadth of clinical applications. And we talk about symptomatic and asymptomatic individuals and applications throughout the lifespan. The purpose of testing can also be varying. For example, to establish a diagnosis, to understand how the condition is likely to progress, assess the risk of developing the condition, or inform therapeutic choices. Genomic data can also be stored and reanalyzed in the future, which adds further value further down the line. And most importantly for us as health economists, the value also extends beyond the individual that is being tested to the broader family and the society. And this complexity has challenged how we evaluate and demonstrate value and value for money, but it has also challenged how genomics fit with current health technology assessment processes, and I will reflect on both of those things. We can think about the value of genomics in terms of how rare conditions affect patients, the health and the quality of life and the well-being of patients and the family. And our first research that you can access through the QR code has demonstrated that it has a significant impact on in this case, parents' quality of life. Parents experience a child's condition. And what we found in our evidence that parents had that 33% of the decline in the child's quality of life was transferred on to parents. And that sort of decline in parental quality of life was not only statistically significant, but it was also clinically meaningful when it's compared against the population quality of life. So they have a detrimental effect on quality of life, and that's also demonstrates the opportunity of genomic medicine to improve the health and well-being of patients and families. Rare diseases are also very costly, and with Australian Genomics, we try to link our data, clinical, genomic, inpatient, outpatient medication, so provide a quite comprehensive picture of how rare conditions impact on the costs and the healthcare system costs. And apart from the long diagnostic odysseys that we found that can range up to 23 years, we found that the cost per patient annually is very high, approximately $16,000. Now, if you project that cost across the diagnostic odyssey, it is quite significant. And that also demonstrates the opportunity, again, of genomic medicine to reduce those healthcare system costs. Now, genomic testing has a cost. And that cost may be depending, for example, the technology, whether it's a genome sequence or exome sequence. But it may also depend on the clinical context and the purpose of testing. And the question now is for healthcare system, is this cost justified on the basis on the improvements on the health and well-being of patients and families, or reduction on those downstream healthcare system costs? And this is the question that we try to answer. So first, we wanted, through a series of focus groups with patients and members of the public, we wanted to understand what is the value proposition of genomic medicine. And through those discussions, people were talking about the diagnostic utility, so the ability to understand what's causing the condition. People also talked about the clinical utility, which is the ability to improve clinical management and outcomes for patients who experience the condition. People also talk about the non-health outcomes of genomics. For example, understanding how the condition is likely to progress in the future, enabling family planning, enabling peer support. These were also outcomes that were very important to patients and families. And also the process utility, reducing diagnostic odyssey and associated uncertainty for patients and families was very important. Now, as health economists, if we understand how much each one of those outcomes is valued, then we are able to understand the overall value of testing in any given clinical context. So through a series of surveys that we've done with patients and members of the public, we found that the outcomes of genomic medicine are highly valued, and especially in the childhood context. And this is the blue bar on top that you see in the childhood context. The outcomes of genomic medicine were valued from about $4,000 to up to about $11,000, depending on the risks and the benefits involved. If the outcomes of genomic medicine for children were only informational gains for the family, then we are in the lower end. But if you're able to cure the condition or improve the condition, then you're talking about the outcomes on the higher end, about $11,000. For adult patients or at-risk individuals, the value is a bit lower, but still, it's quite significant. So the outcomes of genomics are highly valued by patients and the public. And any other studies that we've done within specific clinical contexts, not just us, but other people as well, you can see that the outcomes are highly valued. Now, the beauty with this work is that you can understand the net benefit of genomic technologies. And you can understand, or you can also determine whether the cost of genomic medicine is justified. And this is what we've done. And these are 3 examples of economic evaluations, not only because of the methods that we've used, but also because they represent very well the broader literature. So in the first one, you have applications of rapid testing. This is genomic testing that has a very quick return of results that enables improvements in the outcomes of children, particularly for children who are acutely unwell. This is children in intensive care units. In this case, we demonstrate that for every child that you test, you save about 30,000 Australian dollars, which is about 20,000 US dollars, and which corresponds to an annual saving of about $7 million in Australia. This is an application where consistently across studies, not just by us, but others, that is demonstrates significant cost savings to the healthcare system. Another study that we've done is for children with mitochondrial disorders. And again, we demonstrate that for every child that is being tested, you save about 9,000 Australian dollars. This is about 4,000 US dollars, which corresponds to about $1 million saved per year if that is being implemented in Australia. And it has now been implemented. And again, for rare diseases in children, consistently what we find is that cost savings to the healthcare system. When you include adults, the picture may change. So you're probably talking about cost effectiveness, but in childhood context, there are cost savings. In the evidence review that we've done with the World Health Organization and Cancer Australia, we've mapped out the evidence across the cancer care continuum. And that ranges from the prevention and early detection of cancer to treatment all the way to the end of life. And in the second column, you see the different cancer types. And here the picture is more mixed when compared to the of rare diseases. And where we found that there is the largest convergence of cost effectiveness across contexts was in the breast and ovarian cancer, colorectal and endometrial cancer, and multi-cancer in the early detection and prevention stage, but also for non-small cell lung cancer, breast and blood cancer when in the treatment phase of the cancer. Now, for other cancers, the picture was more mixed. The evidence was mixed or insufficient. Most importantly, though, there may be other applications like rare cancers or cancers of unknown primary, where the value proposition may be more apparent, but we didn't have any evidence in the published literature. Now, governments and decision makers are faced with complex decisions, and they may. And at the moment, I talked about specific applications of cost effectiveness. The decision to implement in the healthcare system requires additional sort of information on top of cost effectiveness, for example, equity. And the question that we asked with Australian Genomics was, can we enable a standardized way to measure and value genomics to support policy decisions? Essentially, how can we help people and governments to prioritize use cases, clinical applications of genomics that generate the largest value? And this is how we talked about the concept of cumulative and preference-based scoring of utility. So we wanted to bring everything on the same scale. So the first step was trying to understand what is important for decision makers and governments in terms of prioritizing genomic applications. And through 2 rounds of a Delphi study, we identified these 5 domains: diagnostic domain, clinical domain for the patient, family utility domain for the family members, whether it's cost effective or not, and societal utility, which is about the equity. So diagnostic utility is the level of diagnostic yield that we achieve in a given clinical context. Clinical utility is the type of clinical utility that is achieved for the cohort, for the group. It can be only prognostic information, all the way to symptom management and health outcomes. Family utility is about informing practical life planning and self-knowledge, or enabling cascade testing or reproductive planning. And as I said, so whether it's cost effective or cost saving or not, and how we impact on equity of access to diagnosis. These were the outcomes that were important in Australia to decision makers. And this is through a series of, as I said, sort of Delphi study with policy, clinical research, and advocacy leadership experts that we did here in Australia, 45 members of them. So the second step was trying to understand how important these were to them. And in this slide, it shows the exercise, which is a multi-criteria decision analysis that we did with them to generate the weight, essentially how important those were in their decisions. And you can see that the clinical utility is the most important domain, followed by societal utility, diagnostic utility, economic and family utility. We can also make comparisons between them in terms of how important each one of those is. So clinical utility, you see they have a preference weight of about 30%. Which is 3 times essentially more important than family utility, that has a preference weight of about 10%. Or 2 times more important than economic utility, which has a preference weight of about 15%. Now, most importantly, this allows us to bring everything on the same scale and essentially compare those apples to oranges and decide which clinical applications generate more value. We monitor all the genetic and genomic applications that have been introduced in Australia. And in this slide, you'll see that the numbers of genetic and genomic applications that have been introduced since 2014 has tripled over time, over this decade, yeah, which represent about 14% annual growth rate. Now, the growth in utilization of those applications has been much lower. So making genomics available is one thing, but realizing the value is the second, is another. So it may require consumer awareness, it may require provider knowledge. So there are more things that determine that helps governments realize the value of genomics. And that's my last slide. So to realize the value, we know that it provides value, but to realize it requires some ingredients, one of which is these collaborative networks. It requires a wide geographical reach and adaptive leadership at multiple levels. We need to think about whole of system approach when evaluating genomics and implementing genomics to realize its value. And I know Dean will talk more about that, but the principle is how can we set up a learning system in which real-world data are used to evaluate and reevaluate and inform and optimize implementation of genomics to essentially optimize those health and economic outcomes for health systems. I will leave it here and I will answer more questions, but before I close, I want to thank the Australian Genomics leadership, Catherine Tiffany Botwood and John Christodoulou, and my long-standing collaborators, Zornitsa Stephanie Best, and my team at the Economics of Genomics and Precision Medicine Unit. Thank you.
Thank you, Elias, for your excellent presentation. So genome technologies have to demonstrate value for money, improve quality of life, and this kind of technology can generate value beyond health for the entire family, but they are very expensive, and sometimes the treatment are not cost effective. And so the government have they have a lot of challenge to prioritize this kind of technology that to find which one are more cost effective. And so also the government have to consider improve equity in decision making and realize the real value of this kind of technology. Thank you very much for being here with us today, because in Australia it's so late. And thank you. So our next speaker is Ida Schwartz. Ida Schwartz is Brazilian. She's the president of the Brazilian Society of Medical Genetics and Genomics. She has a large experience in developing health technology assessment reports for CONITEC, that's the National Committee for Health Technology Incorporation in Brazil. CONITEC is responsible for advising the Brazilian Ministry of Health on incorporation and investment of health technology into the Brazilian public health system, SUS. She will speak about incorporation of genomic technology for rare disease in the public health system. She will have 15 minutes for her presentation. Thank you very much, Ida, for joining us today. The floor is yours.
Okay. Hello to everybody. Thank you very much, Vania, for the introduction. So I will share my presentation here. So I have no conflicts of interest to declare. And my intention here is to give you an overview about how Brazil is dealing with the question of the incorporation of genomic technologies in our Brazil public healthcare system, the SUS or SUS, how we say here in Brazil. We know that Brazil has the only structured public policy for rare diseases in Latin America. This policy was established in 2014. And what is important about the policy is that one of the aims of the policy is to improve an early diagnosis through expanded genetic testing programs. Of course, this aim, according to the policy, should be followed by an evaluation in reference centers that we call reference centers for rare diseases across the country, and also to provide financial support for high-cost treatments when available within the SUS, but also according to our Brazilian national guidelines or protocol for the care of rare disease. So we have to take in account that the SUS is a federally funded decentralized system. Here we have a table that we can find in this paper published in the Lancet in 2023, where we find the different definitions for rare diseases in Latin America. It reflects what happened around the world. There is no one unique definition for rare diseases, and you see as well that I will not talk here about the definition of ultra rare diseases. So in Brazil, we consider a rare disease those diseases which affect at a maximum of 65 patients in a total of 100,000 individuals. And according to the policy, the care of the rare disease individuals should be done on the National Reference Centers for Rare Diseases. We have now 36 services around the country. Here we have the states, each state with the number of reference centers that we have. And you can see that most of the reference centers are located in the border with the ocean, like in the south region, southeast and northeast regions, with few centers in the Amazon region and also in the countryside. Okay. So I'll talk now about the incorporation of genomic therapies in Brazil, also as an example of the incorporation of the technologies for diagnosis. We know that in Brazil, we have two main agencies that regulate the incorporation of those therapies in the SUS. We have the Anvisa. The Anvisa is responsible for the approval, regulation, and the monitoring of new health technologies through the authorization of clinical trials in the country, registration of new drugs, gene therapies, and diagnostic kits, and post-market surveillance and pharmacovigilance. And the CONITEC assesses and recommends the incorporation of health technologies into the public health system. So we can have products that are approved or registered by the Anvisa, but are not recommended by the CONITEC, for instance. And if we want that a product, a therapeutic product or a product for diagnosis is incorporated into the SUS, we have first to submit a request for incorporation. And this request can be proposed by patient association, medical societies, pharmaceutical companies, or even by the Ministry of Health. And after the submission is done, the submission will be reviewed according to the scientific evidence and, of course, economic aspects. And after that, when you have like the results of the analysis, it goes through the third step is a public consultation where the general population and also patient advocacy groups can provide feedback. And the final decision is done by the Ministry of Health. So here we have, I don't have enough time to go through this fluxogram in details, but is all the steps that Conitec develops to analyze the requests for incorporation, okay? And all the steps are linked to the health technology assessment steps. But we have to keep in mind that incorporation is not a synonym for implementation, okay? So we have some products that are incorporated into the SUS, but that the usage of the product was not implemented yet, okay? So here we have, I had a picture from a paper that we just published about enzyme replacement therapy for Pompe disease in Brazil, just to remind you and to point out that the times are very different. So here in 2007, we have the Anvisa approval for the first enzyme replacement therapy product for Pompe disease that we had in the market, so L-glucosidase alpha. But just in 2019, okay, alpha glucosidase alpha had its use covered by the SUS, but only for the infantile type. And you see that the implementation occurred only in 2020, 1 year after. Therefore, through the publication of the Brazilian guidelines for management of Pompe disease. And now we had in 2021 the evaluation for the Anvisa evaluation for a second product for Pompe enzyme replacement therapy for Pompe disease, the alpha-glucosidase alpha. It was registered. In 2021, the Conitec evaluated the indication of the use of L-glucosidase alpha for the late onset disease, but was not approved. In 2022, again, L-glucosidase alpha was reevaluated for late onset Pompe disease, and the decision was maintained, or the late onset Pompe disease patient has not cannot receive the enzyme replacement therapy with L-glucosidase alpha through the normal SUS pathway, okay? And now we have also to keep in mind that we have some products for gene therapy that have been incorporated in the Brazilian public health system, and they were incorporated through the linked through the sharing market sharing risk agreement. Okay. Regarding the genetic and genomic tests, we have in Brazil some projects that are created under the name of Brazil Genomes or Genomes Brazil, but they are research projects, okay? So they were all funded by money which comes from research, okay? This is one of the things that in the field of rare diseases are very important, that we know that we need research for knowing many aspects of the rare disease course, for instance. But our government is using research as well to develop the genomic technologies in the country, with the purpose that after the developing is performed, it could be a translation, okay, from the research field to the clinical field. So we have here one overview of all the research projects that we have in Brazil involving large-scale sequencing, and as we can see here, we have rare disease genome project, okay? And there is also a Brazilian General Coordination for Rare Diseases, which is working on some projects to build a capacity for exome sequencing in a clinical ground, okay? So the first thing that we had to do is to really know what is the availability of genetic tests in public health services in Brazil. As I pointed out, we have the capacity, but we have the capacity in research grounds, okay? In the SUS, the reality is a little bit different, as we can see in this paper also published by our group. We have about 23 centers you see in Brazil. They are shown here. Here is the centers which have molecular diagnostic procedures in their practice. So very few centers, reference centers for rare disease, which offers this analysis to their patients. And regarding exome sequencing, again, in the SUS, it is incorporated in the SUS only for the investigation of intellectual deficiency of unknown cause. This is the only reason for that we can ask an exome sequencing in the SUS, okay? And we can ask as a part of a procedure that we call ambulatory procedure authorization that exists only in the reference centers in Brazil, okay? And you can see this kind of a procedure. There is not a money value established, at least not yet, okay? So we need to find an affordable price, a cost-effective value to introduce a new procedure in the SUS table and broaden the clinical applications of exome sequencing. And what are the challenges that we have now in Brazil? We have a relatively small number of medical geneticists in the country. We have also few bioinformaticians in the SUS. So we have to train these bioinformaticians since the bioinformaticians that we have, they are mainly focused on other non-human organisms. we have to think about the data storage and the other things like the consent to reevaluate the variant of unknown significance that we can find in those tests. Again, coming back to some research projects that has been developed to try to find a solution for those problems in the SUS. We have here an initiative of our National Institute of Science and Technology for Rare Diseases, the INRARAS. So the INRARAS is testing now a workflow pilot study for performance of exomes in SUS. So according to this project, we will evaluate 300 to 500 patients with for different reasons, and those patients, they will come from 5 managing centers. We will have the pre-test counseling and sample collection at the requesting managing center, and the analysis will be made only in one center, a hub center at Fiocruz from Rio de Janeiro, and the data will be interpreted by the multidisciplinary team, including people from the requesting center, and the post-test counseling will be performed at the requesting managing center. Okay, I thank you very much for your attention, and I will be available for questions afterwards. Thank you, Vanya.
Thank you, Ida. Thank you very much for a presentation. As you present, Brazil has a very well-structured process for health technology assessment, but has a huge country, has a lot of challenge in the implementation of technology. And for genomics technology, the challenges are even greater. There are, for example, uncertainty about long-term benefits and costs. So it's very important, it's necessary to have data and integrated information system included to develop management agreements that Brazil is trying to do now. So a quick reminder that please feel free to submit the question in the QA box below the screen. You can write your question in Spanish, also in Portuguese, and I'm gonna try to translate. And Gabriela will present our next speaker.
Thank you, Vanya. Yes, our last speaker is Dr. Dean Bagier. He is senior scientist within the Cancer Control Research, British Columbia Cancer, and associate director of the Academy of Translational Medicine at the Faculty of Medicine at the University of British Columbia in Vancouver, Canada. And his talk will be on next generation sequencing in oncology, challenges in economic evaluations. Dr. Bagier, thank you.
Hello, good day to you all, and thank you all for participating today. Thank you to the Pan American Health Organization for organizing this fascinating webinar, and to my fellow panelists for their excellence and illuminating talks. I am in Vancouver, British Columbia, which is the traditional, ancestral, and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations. We'll talk a little bit about indigenous genomics in the later half of my talk. But broadly, I'm really interested in trying to illuminate or talk and focus about how we think around policy and frameworks that are needed for the evidence generation that allows for a regulatory and reimbursement policy setting to try to address the long time it takes to actually get some of these really life-saving technologies to patients and families. So in terms of the challenges of implementing, reimbursing, and regulating next generation sequencing technologies, highlight some of these challenges which have been touched on before, but we published this nice paper just a few months ago talking about, well, what are the challenges in deliberating on and implementing these really important technologies. And so we have 4 outlined here, and we've talked about them a little bit today already, but I'll just quickly touch on a few of them. The challenge of defining the evaluative scope is really meant to talk about those complex clinical and economic trajectories that complicate defining, how we assess, how we think about assessing both effectiveness and cost effectiveness, including things like the return of incidental or secondary findings, including, as we heard, variants of unknown or uncertain significance, and how we think through the different kind of approaches to understand both value, effectiveness, and cost effectiveness. The second challenge that we highlighted is this idea of managing evidentiary uncertainty. And what this means is that there is a lack of high quality experimental data through randomized control trials, both in oncology and in childhood rare diseases, for example. What this means is that there's a limited evidence base on cost and efficacy and clinical effectiveness, which is really challenging the deliberation around regulatory and reimbursement in our healthcare systems, not only in Canada, but globally, as we've seen. Ilias talked about how do we think through incorporating non-health preferences, so those type of preference-based utilities, what we call utility in economics, that are not captured by or incorporated into conventional evaluation. What is the value of understanding having a diagnosis, for example, that may or may not change the health of the child or the family? And then finally, a very kind of important and underlooked aspect of generating evidence for deliberation is assessing distributional equity impacts. And what this means is that the constellation of these challenges has led to uneven implementation. And even in, well-developed G7 countries, the implementation of next generation sequencing panels and whole exome or genome sequencing is very uneven. So on the right, we have this nice graph of Europe that looks at single gene versus multi-gene testing. And what we see is that the darker the color is, the less it's used. And so on the top, it's very clear that single gene testing is the most used in Europe. And multi-gene testing is very rarely implemented. And so the conversation that we ask ourselves is like, how do we think through generating that evidence? Like how do we understand or use or develop our healthcare systems in a way that allows for the rapid reimbursement and implementation of our sequencing technologies into the healthcare system? And so we published this paper, I guess, in 2022, a few years ago, thinking through, well, what are those frameworks, those policies and practices that are needed to generate evidence for deliberation? And so we came up with this idea of life cycle assessment. And so life cycle assessment is an operationalization of learning healthcare systems. And learning healthcare systems really want to generate and apply evidence to improve health in real time. They try to drive discovery as an outgrowth of everyday patient care. And they really want to ensure innovation, quality, safety, and value, including cost effectiveness in healthcare. And so the idea of life cycle assessment is that we want to standardize study design in the real world, data and analysis to guide the appraisal, reappraisal, and de-adoption of technologies. I'll just take a moment to talk about that. So when we think about real world healthcare systems and the design to get new technologies into that healthcare system, we can start with this idea of managed access. So Ida did a nice job to think, well, what if we were to have a world where we provided rapid access in a managed way to patients and to families? what type of evidence and how do we actually generate that evidence to actually answer that question? Well, how do we move from a managed access world to a world where we implement or pay for this technology or not? And so life cycle assessment is really meant to guide those conversations about data generation. And so the first step is to have that managed access agreement, and then to collect real world data as an outgrowth of actually caring for the patient. And that real world data is meant to will be collected as part of a good study design, which I'll get to in a moment, and then ideally concatenated or joined with other external data sets. And why do we need this? Well, as we know that specifically with rare diseases and even within oncology, finding a signal of benefit is really difficult in precision medicine or precision health context. And that's because we have small benefiting populations, meaning that it's very challenging to think through finding enough patients to actually find a signal of benefit if it's indeed there. And so our approach is to think about collecting our rural data through our healthcare system, and then to join or concatenate that with external data sets. Then we develop real-world evidence packages, which I'll get to in a moment, and interpret and deliberate and update our decision. Through in a managed access world, we have to say, hey, is it effective? Is it cost effective? At several time points. So it's not just an on-off decision. It's a understanding that the evidence base and the data that supports the evidence base is an evolving ecosystem, and that we have to deliberate to understand the impacts on patients and families. So part of this learning healthcare system and realizing life cycle assessment is trying to think through the data that we have. And so I'm in British Columbia, Canada. And what we have done to look at our learning healthcare system is we've created what we'll call a learning commons, where in British Columbia, I'm part of the cancer control system. We provide care for 5.6 million British Columbians, and we have that data, but it's siloed. And so what we've done is we've created the opportunity to join or to link that data. And we've so far captured data on 163,000 patients. Just over 10,000 have gone through a next generation sequencing panel. Just under 1,500 have had whole genome and transcriptome analysis. And this learning commons has actually given us enough data to understand 1.2 million patient years of follow-up. And so this is really the first aspect of how we think through the types of data that are needed to inform regulatory and reimbursement decisions within a healthcare system. The second, and probably one of the most important aspects of learning healthcare systems, is this idea of real-world evidence and the study design to enable real-world evidence. And so here, I don't have time to go into detail this study design, but this study design looked at the question of next generation sequencing for British Columbians in the tumor agnostic or pan-tumor context, compared to single gene testing, to really answer that question: is it effective? Does it provide additional survival? And is it cost effective? And what we did through this study design is we really wanted to mimic or emulate a randomized controlled trial. In order to do that, we have to address the different biases that are inherent in real world data. And so what we've done is we created mapped out all the potential biases, and we've controlled through them through something called synthetic genetic matching. And then we look at things like overall survival and cost effectiveness. Now, when you emulate a trial, it's usually at one point in time. Randomized controlled trials, are on-off decision-making evidence approaches. What we want to do is, instead of just emulating a trial, we want to pursue something called digital twin designs. And a digital twin is just meant to understand, to illuminate or to articulate that we have to look at the whole healthcare system and how it evolves over time. And digital twins are meant to generate counterfactuals or emulate standard of care versus a new intervention, but do it in a way that is continuously updated by data. And that new data gives us more information around effectiveness and cost effectiveness. So in that way, we can have this life cycle approach to decision making. And then my final slide really around thinking through learning healthcare systems, thinking through the data that is needed, thinking through the study design, is really this last kind of challenge, which I think is really important to think through, that is the equity conversation. And we've all talked about today about thinking through equity and the types of analyses that are needed to pursue equity conversation in decision making. And so here is a study that we've been working on for a number of years in context to pediatric rare diseases, specifically idiopathic intellectual disability or disability of unknown origin, and early onset epilepsy. And so here we have developed a economic or decision model to look at cost effectiveness of both the Canadian context in general, so all Canadians in our healthcare system, and then specifically to concentrate on Indigenous Canadians and how they have to navigate the healthcare system. And then we asked the simple question, well, if we were to have whole genome sequencing versus standard of care, what is the cost effectiveness or net monetary benefit, which is another way to look at cost effectiveness of whole genome sequencing versus standard of care? And so on the left, you have the economic model that maps out those trajectory of the patients and the family. And on the right, you have the results. And here was actually quite illuminating, quite interesting in terms of looking at Canadians as a whole or Indigenous as a specific prioritized equity-seeking population. And so what we found is that if we provide whole genomes versus standard of care to all Canadians, the net monetary benefit is essentially neutral in that it's not more costly, it's a little bit more effective, but that net monetary benefit is a little bit ambiguous in terms of whether it provides significant benefits to Canadians. However, it does improve equity a bit. When you use whole genome sequencing, you get more equitable diagnoses. The conversation in the Indigenous context is, however, very different. And so you can see on this vertical axis, the higher it is, the more efficient, cost-effective the intervention is, and the horizontal axis is the equity. And what we found is that compared to the Canadian population, the Indigenous population using whole genomes versus standard of care is quite beneficial in terms of the economic concept of cost-effectiveness or efficiency. It also provides additional access to diagnoses, quite a bit more than you get in the entire Canadian context. And so here we have what we call a win-win situation. If we were to prioritize Indigenous populations as having access to whole genome sequencing, then we'd have both more cost-effective and equitable outcomes. So this is my final slide, and it's just an overview slide to highlight that, for us, we really like to think through regulatory science. That is, how do we improve the standards and tools to assess safety, efficacy, and risk-benefit? We're doing quite a bit of work together with our Indigenous partners, including the First Nations Health Authority in British Columbia, to map out those complex pathways and talk about inequitable outcomes and address inequitable outcomes. We're also working with global systems, including Aga Khan University in Nairobi, Kenya, to think through implementation and building learning healthcare systems around precision oncology. And then finally, kind of the centerpiece of what we do is this concept of a life cycle assessment, where we want to de-silo our health data, and we want to trial in real-time innovation with a view of investment or disinvestment supported by real-world evidence. And so with that, I'm probably over time, but here's my team and my key collaborators. Thank you.
Thank you, Dean. That was perfect timing and a very interesting talk, introducing this audience to the concept of learning healthcare systems and how you're evaluating this intervention in real world scenarios. So thank you for that. And I think many of us are puzzled about the differences in the general Canadian population versus the Indigenous population. I assume, or we'll talk about it probably in the Q&A
Happy to talk
session,
about it,
that being underserved in general may be a component of that, and that may have a lot of impact for Latin America in general. But we'll leave that for the discussion. So I'm going to ask Vanya, Ida, and Ilias if they can turn their cameras back on, so we can spend a few minutes talking and expanding on your presentations and answering the questions that are already being posted in the Q&A. Thank you again.
Thank you. Our first question is for Ida. What's the average time frame for approvals by Conitec? I mean, what's the average time from diagnostic to treatment? Also, in cases where there are not sufficient scientific data to back up a treatment option, are there protocols to follow?
Thank you, Vanya. Very important
questions.
question. No, very important questions. I didn't understand one of the questions, but I will answer anyway, okay? Regarding the time from diagnosis to treatment, I will talk about the rare diseases in general, okay? We have some data from Brazil suggesting that the time from the beginning of the symptoms until the diagnosis is about 5 years, is not very different from the rest of the world, okay? And regarding the beginning of the treatment, okay, it's a bit different. Conitec, according to the law, has like a deadline of evaluation of the requests that was set up in 180 days, okay? This is the deadline for evaluation. Once the product, the technology is incorporated, some studies show that the implementation, okay, so the really access to the technology, it can last or it can be delayed for until 3 years, okay? So there is a delay from the incorporation and the implementation, but it depends on what we are talking to. And yes, we have some national protocols for some diseases, even if like the technology was not approved. And I can give you the example here for Fabry disease, okay, that we had the protocol even in the period where the enzyme replacement therapy had not been approved yet. Okay.
Thank you, Ida. So we have a question from Gonzalo Encina. It's curious, all three of you come from countries that have universal health systems, so I don't know how this will apply, but his question is that it seems that several private genomic testing laboratories, which is something that we use here in Latin America, are struggling to stay in business. In your opinion, if they fail to stay afloat, is the future of genomic testing government funded? I know you're living that future, but I'd like to hear your perspective. Whichever one of you wants to take this first.
I can take it first quickly. So in Canada, we actually do quite a bit of private pay next generation sequencing panels. That has changed over time. But for example, for hereditary cancer screening testing, it goes out of country to the United States. So I think that the challenge here is like a couple fold. It's, do we have the bioinformatics, the pipelines, set up in order to actually do the testing. And so that's one really kind of major challenge around implementation, as Ida has kind of illuminated. And that has been developed over time. And I think that's getting better, at least in context to Canada. I think also, you know, when you look at this idea of generating evidence around, you know, cost and cost effectiveness, you can make the argument more clear if you do it correctly, with respect to the relative advantage. I mean, there's going to be this in-house versus private. The question becomes which is less costly, really, in my opinion. I hate to kind of say that, but like it's going to be when you're government, you have to really think about the sustainability, particularly in payer perspectives. But what we've seen here as we become more efficient in providing or getting our pipeline set up, then actually that's driven the cost down. And specifically also as aluminum machines, for example, we use aluminum machines a lot, have gone less in price, and it's been more of an easier conversation around moving away from private pay to public pay.
Thank you. I don't know if Ida or Elias, you have anything from your perspective to add to that?
I would only see sort of that the equity thing is about sort of who pays for the test. I mean, it's not who delivers it; it's about also who pays for it, and the equity aspect comes on board here. Promoting equity, I think, sort of is important. That it involves no out-of-pocket cost really. So,
Thank you, Ida.
Yes. I think this is a very important question. Here in Brazil, 20% of the population use the private system, okay? And I have, as I work mainly on metabolic diseases, I have to tell you that my main concern here in Brazil is regarding the evaluation of genomic tests for newborn screening, okay? Because newborn screening through genomic tests has been done here in the private system without like any regulation or evaluation, okay? And this is something that makes me very, very, very worried, because we follow all the discussions and all the UK newborn screening project, and here we see the things happening okay in the private sector without data analysis or and without a talking between the private and the public health systems.
Thank you, Ida. Yes, the heterogeneity makes it very difficult to understand what's going on at different levels, for sure. Thank you.
The next question is from India. Hyoti, I don't know if it's possible to speak. I don't know how to speak. Hyoti, I think so. Thank you for informative and insightful talks. I'm Dr. Hyoti from Carnicles, India. My query is about genetic counseling and create awareness among the patients and other about genetic testing. What is it facilitated, and up to what extent? And any other speaker can answer my query. Thank you.
I can add something. So from the research that we've done with patients, having genetic counselors and sort of is very important to them. And also creating awareness really increases the uptake of genetic testing, of genomic testing. And in here in Australia, different states have gone through different awareness programs, or the extent to which the awareness programs have been implemented. And you can see, for example, here in Victoria, we've seen much higher utilization of genomic testing because of those awareness programs relative to other states. So it is very important, and it drives uptake and value of genomic testing.
Here in Brazil, this question has been trying to be solved again through some research initiatives that our agencies are having, like promoting research projects on literacy about genetics, okay? Because of course genetics is a science relatively not easy, okay? We have to deal with some very difficult concepts. And then now we are talking here about genetic tests, but I think we also have to keep in mind that we have the gene therapy, okay, and the patient to be able to accept or not the gene therapy process, they have to understand what is gene therapy. So here we are dealing or trying to emphasize a lot the necessity of an increase on literacy about the population, about the genetics in general.
I think maybe I'll just add to that. The other side of the equation, of course, is do we have enough genetic counselors to actually facilitate some of these really important conversations? And I think the answer, at least in Canada, is like, not really. We need to do better education and have better training programs, or more training programs, not better. And also, just because Elias highlighted equity too, I'll just also say, different people talk different languages and experience the healthcare system differently, right? And so for example, in the Indigenous or First Nation context in British Columbia, you might have a genetic counselor, but do they know the specific context of that nation? Do they know the challenges and the inequity and the racism that happens as routine almost within our healthcare system? And so training counselors to be able to have that conversation in a way that connects with the family is really important.
Absolutely. Thank you. Yes. And by the way, in next week, we will have another WHO organized webinar on education and training of the healthcare workforce. So I'll try to find the link and put it in the Q&A, because definitely education and awareness are key to move this forward and have the appropriate evaluations. So I'm going to test my portuñol here with the question from Andresa Braga. Or perhaps you want to repeat it, but yeah, just so I don't mess it up.
It's a question from Andresa Braga from Brazil. Good afternoon. I'd like to ask about the issue of access to genetic diagnosis. We know that some tests, such as whole exome sequence mentioned in Dr. Zida's presentation, are still not incorporated or valued in the public health system, SUS. At the same time, we already have medicines approved by CONITEC for genetic diseases, such as Zolgensma and other medicines for spinal muscular atrophy. Given this, how are these patients diagnosed so that they can access treatment if the necessary genetic test is not yet available through the public health system, SUS?
Is it for me, right?
Yeah, for you.
Hi, Andresa. Thank you for your question. Actually, I gave the example of exome sequencing, okay? But the Sanger sequencing and like the MLPA and other techniques that we use, for instance, for spinal muscular atrophy, they are incorporated in the SUS, okay? And so at least legally speaking, every reference center on rare disease of the country should be able to give access to those tests to the patient, okay? Regarding exome sequencing, if you need the exome sequencing for other indication besides the intellectual deficiency, we can include the patient in a research project like the Brazilian Rare Genome Project, or as we know, the other way is to the judicialization, okay?
Thank you, Ida. You can do the next question. The next
Sure.
question.
Turn my microphone back on. So there's a question from Carlos Franco asking whether the type of sequencing technology and the different companies that are available affect these cost effectiveness evaluations.
I can have a go at that. Like, the short answer is yes. The long answer is really about trying to understand things like the cost of reagents, for example, the cost of the sequencing, the cost of the bioinformatics pipeline, and then to actually, in the end, also incorporate, as Elias and I kind of highlight, as like the downstream implementation costs. And so, Elias talked about, I think, like microcosting and really trying to understand like those underlying dynamics about private pay, public pay. If it's public pay, which platform do you go on? There's so many different options. And so there's been this nice rich history, I think, in economics and the health economics literature around actually going to the healthcare system or what have you to say, okay, well, it's actually fun. It's like you take a timer and you say, okay, this is how long the bioinformatics takes, right? And then you incorporate the cost, and then you incorporate something called throughput, which is how many samples do we have on hand to sequence at the same time, which affects kind of the first patient cost. The more samples, the more you drive down the cost. And so really understanding those different dynamics is really important when you kind of try to deliberate on which platform do we go to? Do we actually keep, make people private pay, or do we actually pay as a public healthcare system for private pay, which, as Ida is like really importantly kind of identified, like you lose your data, right? And if we want these learning healthcare systems, we need that data, right? And so there's a whole bunch of different dynamics that surround that.
The only thing I would add to that is, yes, it affects the accuracy of what the economic cost it actually is. But in terms of cost effectiveness, it doesn't really change much, because the question is about whether genomic testing is cost effective or not. And within the cost of genomic testing, we incorporate uncertainty on those inputs that determine the actual economic cost of testing. So it doesn't really affect the cost effectiveness itself, but it's important in terms of understanding the economic cost and setting appropriate reimbursement sort of prices, etc.
Thank you. And I think another issue is which ones are approved for clinical testing, as compared to the ones that are happening in a research environment.
And research is a lot more expensive than a clinical testing,
Could
right?
be. Yeah.
So.
Yeah. Our next question is for Dean. Why is GS more cost efficient in indigenous population?
Yeah, no, that's a really good. I was hoping we'd get that question. 15 minutes is a lot of time to talk about that analysis, but maybe I'll just highlight. So, so this is a context of childhood or pediatric rare diseases, and diagnosing things like intellectual disability that is of unknown origin, etc. And what we need in order to do that efficiently and do a period is something called a background variant library. Background variant libraries, what they do is they have, there's a few of them out there, Nomad being kind of the most widely used. But what it does is it takes populations, ideally populations from the entire world, and it sequences those populations to understand normal variation in our genome. Okay, and that's our reference case, right? So say, okay, well, this is what we think is normal variation. And then you have a child or a family come through and you look at their DNA, their genomic outputs, and you compare that to this background variant library to try to find those rare kind of instances or variants that may be causal of the condition. And so what we know in these background variant libraries internationally is that they are very representative of white European people. So that means that we don't know what the variation is anyways of white European ancestries. And so the outcome of this is that for indigenous populations like First Nations of Canada and other indigenous populations that don't have representation in these background variant libraries, that means that we have more variants of unknown or uncertain significance. And of course that limits our ability to give a causal diagnosis. So first of all, so the big challenge, and this is reflected in that economic valuation, is that, hey, once you have a whole genome sequencing, you actually get a pretty good idea of the sequencing. And then we also compare that, we've been building a background variant library that is indigenous. And so that has helped increase the rapid and accurate diagnosis of these families. So that's number one. Number two, and I kind of alluded to this, and this is my hunch, we need to do more digging around on this, is that, this is under a very controlled kind of research setting where we go to communities and sequence, right, using whole genome sequencing. But as a fact of everyday, in our comparative standard of care, everyday care, and as a kind of fact of Indigenous First Nations people experiencing the healthcare system in British Columbia and across Canada, there is structural racism. We know that. That's not something new to say, right? And so there are everyday challenges that these patients and these families of Indigenous ancestry encounter. And when you provide things like genetic counseling that is sensitive to that context, when you engage those families in a thoughtful way, my hunch is that they're more willing to interact with the healthcare system and are therefore able to actually trust going through something like genomic testing, which is a deeply personal process from our kind of qualitative research. And then when you put this all together, if you provide more diagnosis quicker, the outcome is that you get more equitable distribution. You address that inequity that through this concept of vertical equity, treat unequals unequally to try to even them out. So that's how you get the more equitable outcomes. The cost benefit outcomes or net monetary benefit outcomes really are a reflection of the cost savings and more diagnosis.
Thank you, Dean. So we have time for one more question that we would like to pose to our three speakers. There's a question from Catalina Lopez Correa asking if and how you're including patient voices and patient perspectives to define. The question is about specific clinical outcomes, but I'd like to broaden it to value in general. Thank you.
I can have a first go at this. Hi, Catalina. This is critical. This is absolutely necessary. And for us, I mean, it's been the foundation of our work with Australian Genomics. So understanding, what is important to patients and really trying to incorporate it within our work. And before that, yes, people were talking about, all the aspects, but what we tried to build on that and try to understand how much important that was to them. And I can see now decision makers being a lot more appreciative of the evidence that we have provided and changing or adapting a little bit more pragmatically, though, understanding that this is important and trying to incorporate within their decision making. But it is absolutely critical, Catalina. Thank you for the question.
And I could just kind of, hi, Catalina. Thank you for answering that question. So we've been doing this actually since 2009. And initially when we started doing it, it was qualitative research with children and families around rare disease diagnosis. And then we did something called preference-based analysis to look at the value of a diagnosis. A lot has changed since then. And right now, I think as Elias kind of also knows, is that that is the minimum that we try to do. What now is we want to incorporate patients and families into every part of our research, into the design of our learning healthcare systems, into the design of our research, into the design of our implementation approaches. And that's really key, specifically, as Catalina would know, in terms of Canadian First Nations and Indigenous populations and building that trust, what we call reconciliation. And so partnering actually not right at the beginning of research, before research, years before research, with different nations, with different communities, to make sure that you do research in what we call a good way that builds trust and does not exasperate racism. And so it's actually pretty central into everything we do and how we think about outcomes.
I just would like to add that here in Brazil, Catalina, in the process of evaluation of the technologies, there is a space in the Conitec meetings where there is a patient or a family affected by the disease for which the technology is being evaluated, for the patient or the family to talk, okay, about the situation, okay. And the thing that Dim talked right now, I fully agree. When we talk about research, okay, I think we have to involve the family and the patient in all the process, even in trying to design the questions for research, okay, because sometimes the kind of researchers that we do is to answer our questions and not the main questions of the community, okay.
So thank you to our amazing speakers. We could probably go on for a whole week talking about this, and especially how do we move this to low and middle income countries that have much less genomics and are thinking about how to leapfrog into these services for the patients who need them. So I don't know, Vanya, if you have closing words, and probably Ludovic will too, but thank you very much for a fabulous discussion.
Many thanks, Gabriela and Vanya, for moderating the sessions and conducting and helping to respond all the questions. So I want to thank Dr. Goranitis, who is currently in Australia. It's 2 or 3 a.m. in the morning, so we really appreciate the effort of being here. Thank you so much. Also, Dr. Ida Schwartz and Dr. Dean Regler, thank you for the presentation. I think we had a very good participation. Almost 300 people were connected today on the session. We had a lot of questions. So I want also to take the opportunity to thank all the team that was behind this, in particular Nitza Muniz, who is finalizing today her internship, and she was organizing this session for us today with all the team, Silvina, Kim, and Magalis, and all the teams of translators. So thank you for that. We're having these sessions every 6 weeks to 2 months. So we invite you to the next session. The link to the Evidence Hub listserv was included there in the chat. So if you want to be informed of additional meetings and additional webinars, you can also join the web. So many thanks to all, to my colleagues from Alexandre and Vanya, that we work together with them in this and many other topics. And well, have a nice day, and thank you until the next time. Bye.